And let me go get the document. Let me advance. Okay, good. It works. Okay. Now let's see if I can get my screen back. Okay. All righty. Are we ready? I'm going to start.
Yep.
Okay, here we go. Hello and welcome to Neuro Challenge Foundation for Parkinson's. I want to thank you for joining us today on this presentation by Allison Hauser. It's called Parkinson's Disease and Sexuality, a Comprehensive Psychoanalytic Approach. And for those of you who don't know anything about NeuroChallenge, maybe you've just found us on social media and decided to register for this webinar. Let me tell you a little bit about us. We are a nonprofit organization that serves the Southwest region of Florida. And we primarily serve people with Parkinson's and their care partners by providing educational opportunities, therapeutic programs. Those could be things like exercise or art classes. And we also run at least one support group in person in every county that we serve. So we're happy to be able to bring this educational program to you today. And I am going to introduce Allison. But before I do that, if you have any questions at all that come into your head during this presentation, I urge you to go to the Q&A bubble at the bottom of your Zoom screen and go ahead and type the question in as soon as you think of it. There will be an opportunity at the end of this webinar for Allison to answer those questions, but if they aren't there, then we can't have anything to answer. So go ahead and just pop them in there whenever you think of the question, okay? If you're having any difficulties with hearing us or some kind of technical problems, you can also put that in the Q&A and I'll see if I can troubleshoot that on the back end. All right, now without further ado, Allison Hauser is a mental health counselor in private practice at the University of Florida Shands Psychiatric Hospital. She was trained at Northwestern University with advanced study in psychoanalytic theory and technique. She's also presented on psychedelic assisted therapy at UC Berkeley. Allison is dedicated to making the unconscious conscious to foster lasting change. She is currently accepting patients in her private practice, and you can learn more about that at allisonhauser.com. And anybody who's interested at the end of this presentation, I will also be sharing her contact information via email to everyone who registered for this webinar. And that way, if you need to reach out to Allison, you'll be able to do so. We are also recording this webinar, so it will be able to go on our YouTube channel in the next few weeks. So welcome, Allison.
Hi, thanks for having me, April.
Yeah.
Okay, well, I think we should just dive right in. That was a great introduction, so I don't think I need to say more about me.
All
Um,
right.
yes, thank you to April and thank you to the Neuro Challenge Foundation for today's presentation and allowing me to, make the unconscious conscious and raise awareness about modern day psychoanalysis, particularly as it relates to PD and sexuality.
Okay.
Next slide, please. Well, next over there.
Okay. I did kind of introduce you.
So, sexual dysfunction represents one of the most prevalent yet underaddressed non-motor symptoms of Parkinson's disease. The statistics are striking. Up to 87.5% of women and 68.4% of men with PD experience sexual difficulties. Yet in clinical settings, these concerns often remain unaddressed. What makes this topic particularly complex is its multifaceted nature. Sexual changes in PD aren't simply physical to be managed pharmacologically. They represent instead profound disruptions to identity, intimate relationships, and psychological well-being. Next. By the end of today's presentation, you should be able to understand the prevalence and impact of sexual dysfunction in PD, apply psychoanalytic perspectives to enhance clinical care and support, recognize the complex interplay between neurobiological mechanisms and psychological factors, and develop practical strategies for supporting patients and partners through sexual changes. Next. Great. Parkinson's disease is a progressive neurodegenerative disorder affecting approximately 1% of the population over the age of 60. While most people are familiar with classic motor symptoms like bradykinesia, tremor, and rigidity, our understanding of PD has evolved significantly. We now recognize Parkinson's as a multi-system disorder affecting numerous bodily functions beyond movement. This broader understanding is crucial when considering sexual health, which involves complex interactions between motor function, autonomic systems, cognitive processes, and psychological well-being. Next slide. Now let's turn to psychoanalysis, which offers valuable frameworks for understanding the deeper psychological dimensions of sexuality and PD. Founded by Sigmund Freud in the late 19th century, psychoanalysis explores unconscious processes that influence our behavior, emotions, and relationships. Contemporary psychoanalytic approaches, particularly those in the relational tradition established by theorists like Sandor-Ferenczi, emphasize the intersubjective nature of human experience. So for individuals with PD experiencing sexual difficulties, psychoanalytic therapy offers a space to explore not just symptom management, but the meaning of the changes in the context of their life narrative and their relationships. Next slide. Sexuality has been central to psychoanalytic theory since its inception. Freud positions sexuality as fundamental to psychological development, though his conceptualization was much broader than common understandings of the term. And we now recognize that theories have been updated and we've made mistakes and have since revised things. Early psychoanalytic theory focused primarily on drive-based understanding of sexuality. However, as psychoanalytic theory evolved, particularly through object relations theorists like Melanie Klein, the emphasis shifted toward relational aspects of sexuality. Contemporary psychoanalytic approaches integrate biological, psychological, and relational dimensions of sexuality. This integration is particularly valuable when addressing sexual difficulties in PD, which similarly require multidimensional understanding. Next slide. Thanks. Psychoanalytic theory offers us several frameworks for understanding the psychological impact of chronic illness like PD. These frameworks are particularly relevant when addressing the sexual difficulties. For instance, the concept of embodied identity refers to our fundamental sense of self as existing within and through our body. Chronic illness, like PD, can profoundly disrupt the sense of self, creating a sense that the body is foreign or unreliable. Next, object relations theories help us understand how illness can disrupt our relationship with our own body, which, besides our mother's body, is our own first object. When PD changes our bodily functions, including in the mind, it can feel like a betrayal of this object, leading to psychological splitting and detachment. And lastly, attachment theory, which provides insight into how we cope with illness-related changes in relationships, including our intimate ones. These psychoanalytic frameworks offer a deeper understanding of the psychological dimensions of sexual difficulties in PD. Next slide. The prevalence of sexual dysfunction in PD is really striking. Studies consistently show rates of 60 to 80%, with some research suggesting even higher numbers. These difficulties affect both men and women and those in between, though the specific manifestations may differ. For women with PD, common issues include reduced arousal and lubrication, difficulty reaching orgasm, decreased desire, and overall sexual dissatisfaction. For men, erectile dysfunction is most common, followed by ejaculatory problems and decreased libido. These statistics represent not just physical symptoms, but profound impacts on quality of life, relationship satisfaction, and our well-being. And it should be known that there are little studies on genders and sexes beyond the binary. Next slide. Sexual dysfunction in PD has a complex, multifactorial etiology or origin. Neurobiological factors include dopamine deficiency, affecting reward and motivation, autonomic dysfunction, impacting physical sexual response, and changes in other neurotransmitter systems. Psychological factors include depression and anxiety, which affect up to 40% of PD patients and directly impact sexual function. Body image concerns, fear of rejection, and performance anxiety further compound these issues. Relationship factors, including changing roles, communication difficulties, and the impact of caregiving on intimate dynamics, are compounded. Medication effects add another layer of complexity, as dopaminergic drugs can have paradoxical effects on sexual function. Next slide. Medication effects on sexuality and PD are complex and sometimes even paradoxical. Levodopa and dopamine agonists can improve sexual desire in some patients, while simultaneously contributing to erectile dysfunction or other physical sexual problems. For instance, some patients experience hypersexuality as a side effect of dopaminergic medication, particularly agonists. This can create significant relationship strain and ethical dilemmas for healthcare providers. Timing of medication in relation to sexual activity is crucial. Many patients experience fluctuations in function or on-off periods that directly impact sexual capability. Optimizing medication schedules to ensure patients are on during desired times for intimacy can be a key strategy. Next slide. Psychoanalytic theory offers us several key insights for understanding sexual difficulties in PD. First, symptoms often carry symbolic meaning beyond their physical manifestation. For example, erectile dysfunction might unconsciously represent feelings of powerlessness related to the disease. Second, the concept of narcissistic injury helps explain why sexual changes can feel so devastating. They represent not just physical limitations, but wounds to core identity and self-esteem. Third, psychoanalytic theory recognizes how current difficulties may activate earlier in our lives psychological conflicts or traumas. For instance, dependency needs in Parkinson's might reawaken unresolved issues from early development. And finally, the intersubjective nature of sexuality means that changes affect not just the individual, but the relational field between partners, creating complex dynamics that require attention. Next slide. One of the most significant challenges to intimacy in PD relationships is what researchers term the caregiver-lover role conflict. When one partner provides intimate physical care, boundaries can blur, making it difficult to transition back to an erotic connection. Many caregivers and partners express this dilemma. For example, how can I be wiping them down 1 minute and feeling desire the next? This role confusion can lead to avoidance of intimacy, resentment, and profound sadness for both partners. From a psychoanalytic perspective, this conflict involves complex, unconscious processes. The caregiving role may activate parental introjects, or how we are reminded of our parents, making erotic feelings seem inappropriate or taboo. Conversely, the dependent position may trigger shame or regression into childhood-like behaviors that interfere with adult sexuality. Addressing this conflict directly is crucial for maintaining relationship quality and requires creating clear psychological and time boundaries between caregiving and intimate activities. And to note, we will have case studies to exemplify these particular dialogues and dialectics. Okay, next slide. The concept of embodied identity is central to understanding sexual difficulties in Parkinson's. Our sense of self is fundamentally embodied through our body. We are we. We experience ourselves through and within our physical bodies. PD disrupts this embodied identity in profound ways. Patients often describe feeling betrayed by their bodies or experiencing their bodies as alien or other. This disruption extends to sexual identity as individuals struggle to reconcile their sexual self-concept with their changing physical capabilities. From a psychoanalytic perspective, this disruption can lead to psychological splitting, difficulty integrating the sick body with the sense of self. Individuals might then feel detached, observing their body struggles rather than feeling fully present. This detachment impacts intimacy and sexual connection undoubtedly, which requires embodied presence. Psychoanalytic therapy can help patients reintegrate their embodied experience, fostering a more coherent sense of self that includes but is not defined by illness. Next slide. Okay, thanks. Attachment theory. It provides valuable insights into how individuals cope with sexual changes of PD. Our attachment style, whether it be secure or insecure, like anxious, avoidant, or disorganized, influences how we navigate vulnerability, dependency, and intimacy. Secure attachment may foster resilience and open communication about sexual changes. Anxious attachment might manifest as excessive worry or concern about a partner's satisfaction. Avoidant attachment could lead to complete sexual withdrawal when the challenges arise. The caregiver-patient dynamic in PD can activate early attachment patterns in complicated ways. For example, increased dependency might trigger anxious attachment behaviors or defensive self-sufficiency, like doing it all on one's own. Understanding these attachment dynamics help clinicians tailor the interventions appropriately. For instance, individuals with anxious attachment may need more reassurance, while those with avoidant patterns might benefit from gradual exposure to vulnerability. Next slide. Okay. Psychoanalytic therapy offers us unique benefits for addressing sexual concerns in PD. Unlike approaches focused solely on behavioral techniques or symptom management, psychoanalytic therapy explores the meaning of symptoms within the individual's life narrative. The therapeutic relationship itself between analyst and patient becomes the vehicle for change as patterns of relating are explored and new possibilities emerge within the therapeutic space. This is particularly valuable when working with issues of intimacy and sexuality. Contemporary psychoanalytic approaches, particularly those in the relational tradition, emphasize mutual recognition and the co-creation of meaning. This helps patients integrate their experience of illness into their broader identities and relationship narratives. Specific techniques include exploring unconscious conflicts related to sexuality, working through grief about lost function, addressing shame and narcissistic injury, and then fostering new forms of intimate connection that accommodate physical changes. And now we'll go into the case studies, which I think will really make the content come alive. All right. Case study of Elena. And these are fictional, based in true stories of my patients throughout the years, um, but not any one person's story. Okay. So now I'd like to explore Elena's case, which powerfully illustrates erotic aliveness in a changing body. Elena is an 80-year-old white transgender woman married to a cisgender woman in an open marriage. She transitioned midlife and has been on estrogen for 3 decades and had a long history of sobriety. She grew up socialized as a boy in a military family where emotions and sexuality were repressed. She described feeling as if she had no cultural or erotic inheritance. She did attend art school and painted throughout her life. Elena began experiencing Parkinson's symptoms and came to treatment with layered concerns: fatigue, emotional deadness, fears of abandonment, and psychic unraveling. She was hesitant with her doctors, some of whom raised concerns about her estrogen treatments or history of maternal psychosis. She feared disclosing that cognitive changes might invite transphobic judgments or medical suspicions, despite having been stable on these treatments for decades. This led to complex dynamics. Was her fatigue neurological, psychiatric, hormonal, or a deeper echo of early abandonment? She had been separated from her mother during her mother's postpartum psychosis as an infant. Elena wondered whether her body's exhaustion stemmed from Parkinson's, depression, or this pre-verbal wound. In Elena's words, her sexuality had become eclipsed. Her erotic self no longer felt present. Arousal, desire, and orgasm had disappeared. Her partner feared that Elena no longer felt like a lover, and at times, Elena feared she was becoming more of a patient than a partner, a recreation of her dynamics with her mom. But over time, something shifted, and Elena picked up her paintbrush again. Her partner also pulled out their old recordings from her band. Elena told me they cried once while listening to her 70s rock songs, describing the intense impact of each other's presence, a look, a touch, and a tear. She teared up in session, as did I. These tears were cathartic, moving, and in that sense, erotically charged. Stroking hands through tremors and not avoiding them, they created new pathways for intimacy. A cheek kiss became world-changing. They reclaimed erotic touch by building rituals around time and care, and these small acts became music, a rhythm of mutual recognition. Elena started to take up what she called tremor art photography. Her shaking lens captured blurred, unrecognizable images. But rather than failure, Elena saw them as revelations. These images conveyed spirit, essence, and intimacy. She said they mirrored her relationship with people, sometimes unclear, but deeply known. When her fatigue kept her from creating, we explored in session what it meant to simply be and to rest together. She feared being unproductive. She feared disappointing me or being seen as lazy. But the couch became a place of mutuality and trust. These shared moments were warm, grounding, and potent. Sometimes Elena would forget what happened that day, but remember the mood. So she'd name a color or imagine a painting to describe whatever had happened and how it made her feel. When she could, she recorded poems into her phone and shared them in session. Sometimes forgetting was grief-stricken. Other times, though, it felt playful, even erotic. It became a meditation on life's transience and life's mystery. After 8 years of work, Elena passed peacefully in the spring. She found comfort in imagining her body returning to the earth, her atoms continuing the cycle. And just as her mother birthed her, Elena imagined becoming a source of life again through her art, her touch, and her atoms. In her final months, she reflected that her body remains a living medium, ever-changing, still capable of expressing vitality and connection. Next slide, please. Okay. And now we'll move into George after I take some water, and you can integrate what we just heard too. Okay, so now we have George. George is a 72-year-old Black and Haitian man from Louisiana. He's married to his second wife of 30 years. He was raised in an environment where emotional expression was unsafe, growing up in a community where masculinity was equated with protection and survival. Mental health was often framed as a moral or spiritual failing, not a medical concern. George carried this lens into adulthood, often praying for healing, and even wondering at times if a spiritual curse linked to past infidelities or hoodoo even had caused his suffering. George entered treatment feeling overwhelmed by the sexual and emotional fallout of Parkinson's. His face masking, motor symptoms, and impotence threatened his sense of desirability and identity as a man. He said, "Just as I learn how to cry or show love, I fall flat again." His wife's bisexuality and her long ago relationship with a woman haunted him with fears of abandonment. Does she regret marrying me? He wondered. He feared that she might seek out other partners, especially given his inability to please her in all the ways that she longed for. This impotence stirred deep memories of his father's death from cancer, of his mother turning all of her attention to George's sister. George feared becoming his father, emotionally abandoned and forgotten in illness. He resisted couples therapy, worrying I might side with his wife, a repetition of his experience with his neurologist, when he felt he talked, the neurologist talked about him rather than with him. "It's like the two of you are colluding," he once said. George fell into a deep depression, recalling a past psychiatric hospitalization he had in his 40s. The memories were painful of medication side effects then that had included drooling, flat affect, lack of desire and orgasm, and even a drug-induced tardive dyskinesia, all of which felt like a foreshadowing of his present suffering. He blamed himself. "If only I had healed my trauma earlier or worked less or spent more time with my wife and kids. Is this a punishment?" He felt doctors couldn't help and that trying only made things worse. Then his doctor adjusted his medications, and seemingly everything changed. George burst into session one day euphoric. "I feel 20 again." He had experienced his first erection in years and couldn't stop pleasuring himself. The rush was intoxicating, but the fallout was confusing and painful. "Why doesn't my wife share my enthusiasm?" he asked. "I say I feel 20. She says I'm acting like I'm 14. It's demeaning. I thought she wanted this." George described his dreams. Lightning striking the ocean, a woman sawing an apple tree, elephant trunks erupting and collapsing. He said, "I felt so good, like I was on top of the world, but I can't love or feel loved by the most impotent, I mean important person. It's a great fall and hard to bear." George developed a compulsive attachment to pornography, which increasingly dulled his pleasure both physically and relationally. Porn set impossible standards neither he nor his wife could meet, and he felt ashamed and isolated. And he didn't tell his doctor, fearing any change in medication might take away the erection he had waited years for. Shouldn't I be happy, he asked, and shouldn't I know how to be disciplined and how to please her? The shame was palpable. George wrestled with sharing his fantasies with me, especially ones involving masturbation to the idea of me. It was difficult to acknowledge these urges to a female clinician in particular, but this exploration really became key. We processed how it felt to share these thoughts with me and to see that I did not respond with disgust, nor with seduction or intimacy, nor with withdrawal. For George, this was transformative. For the first time, being emotionally exposed did not equal abandonment or shame. This trust eventually extended to his physician. George began disclosing more and, importantly, became willing to come off the medication. He feared the loss of pleasure, but found instead that he retained erectile capacity and let go of impulsivity. What remained was more sustainable, a secure and emotionally grounded erotic life he could share with his wife. George no longer saw his intimacy or identity as broken or pathological. His experience of desire had changed, yes, but it had not ended. The love with his wife endured, not despite Parkinson's, but in tandem with its rhythms and its shifts. Their sexual connection became, as George put it, electric, not based on performance, but on mutual presence and on mutual trust. So that's George. Okay. And lastly, we have Maria. Maria is a 60-year-old Colombian cisgender woman who has lived in the United States for the last 30 years with her American husband. They share a long-term marriage, but in recent years, Parkinson's disease has introduced layers of disruption, not only to their routines and mobility, but to Maria's sense of her own body, sexuality, and emotional agency. As her tremors and stiffness grew, the texture of her own physical touch changed. Maria experienced a chilling disorientation. She no longer recognized her touch as her own, and memories of childhood sexual abuse began to resurface. She began to fear she was becoming a perpetrator herself, even unwillingly. Her bodily changes reverberated in her relationship, and the couple's dynamic slipped into a haunting push-pull rhythm, one evocative of the early families and their lives. In the transference, which is to say how Maria felt about me, Maria at times treated me as if I were one of those figures from her past. Encouraging words of mine were met with irritation or withdrawal. She came to acknowledge, this is how I control things at home too. There was a sense that shutting me down was a form of agency, a way to seize control in a body and life increasingly controlled by image, illness, and dislocation. Attempts at sexual re-engagement with her partner were waning. The fatigue of daily caretaking left her husband little motivation or energy to play, to try new positions, or take erotic risks. And Maria feared getting hurt. Would he be willing or able to try that position the occupational therapist recommended? She wondered. How could I ask him to touch me after he's already spent the day taking care of me? Her longing was paired with guilt. And her partner, now in a caregiving role, developed his own defenses, harboring fantasies of lost loves or turning to seemingly anything other than her. Maria felt abandoned. A fetish emerged and was explored in session, not just as a side effect of medication, but possibly a long-blocked aspect of herself. Raised Catholic in a culturally conservative context, Maria had buried much of her sexual imagination under layers of shame. Maria's body had become an unpredictable terrain, less mobile, responsive, and often alien. She longed for control, and in the absence of it, she expressed frustration toward her partner's fatigue, his emotional coolness, the apparent meaninglessness of this whole illness, the grief of lost function, physical capability, and relational was palpable. She began to dream of punishing a man. These dreams were explored as compromise formations, fantasies where she could regain power in a life now characterized by vulnerability and dependence. Was this aggression a sexual need, a relational longing, a desperate protest against the feeling that connection always had to involve exploitation, push-pull dynamics, or silence? At the same time, Maria grew more assertive in treatment. When she shut me down or reacted harshly to interpretation, it became clear that she was practicing this form of control. She acknowledged resenting the need for treatment itself, the implication that she even needed help. Sometimes my words felt to her like criticism rather than support. When I brought to her attention that I felt as if I were being choked or as if my hands were being tied behind my back, Maria's fantasies also became more vivid and more conscious. As the analysis progressed, Maria became more curious about these emotional patterns. Over time, the punitive fantasies tied to the anger of her condition and feelings of abandonment began to soften. She recognized that her desires still carried elements of possession, yes, but also held a deep longing for stability and closeness. She began to see the value in her partner's peaceful presence, not as a failure of masculinity, but as a foundation for mutual trust. She started to express longing, not for erotic power over, but for shared potency with her partner, the kind of connection she began to experience in session when she allowed it to unfold. Our work helped her distinguish control from care, discipline from safety, and symbolic fantasy from true intimacy. Acceptance of her aggressive impulse also allowed for more liberated, flirtatious play with adaptive tools, fostering the exploration of shadows and desires within the safety of their love. Lastly, Maria's story is one of erotic reclamation, not necessarily through increased sexual activity, but through the restoration of her right to feel, to want, and to say no or yes with authority. Her Parkinson's did not just take things away, it reopened old wounds that, in the space of analytic holding, could be re-examined and to some degree healed. Her body remains a site of pain and limitation, but also of emerging dignity, agency, and new forms of connection. Okay. We can go to the next slide. Okay. Effective treatment for PD and sexuality requires an integrated approach addressing biological, psychological, and relational dimensions simultaneously. Medical management includes optimizing medications and considering side effects, while psychological interventions range from psychoeducation to deeper psychoanalytic exploration, as we saw with our case studies. The most effective approaches integrate these dimensions rather than addressing them in isolation. For example, medication adjustments combined with psychological support that addresses symptom meaning and relationship dynamics often yield better outcomes than either approach alone. Next slide. Partners too face their own complex emotional journey, experiencing grief, anxiety about causing harm, and confusion about changing desires. This caregiver role significantly impacts sexual dynamics, as we saw, creating role confusion and boundary challenges. The psychoanalytic therapy process creates a safe space where these sensitive topics can be explored. Therapy focuses on understanding, again, the personal meaning of sexual changes, working through grief and identity shifts, and uncovering unconscious patterns from early on that contribute to present difficulties. Next slide. Looking ahead, I think we need longitudinal studies tracking sexuality throughout the disease course, preventative approaches, and PD-specific assessment tools, and there are a few out there. Clinical training, then, should emphasize these sexual health assessments and conversations, particularly for specialists working with PD patients. Numerous resources are available, including educational materials from Parkinson's Foundation and Neuro Challenge, of course, our big sponsor today, and clinical guidelines from professional organizations and books on addressing sexuality and chronic illness. Support groups for Neuro Challenge are present in many cities around the nation. And of course, I have to give a big shout out to psychoanalysis and psychodynamic therapy, which is primarily how I dedicate my professional time and career. Next slide. In conclusion, sexual dysfunction represents a significant but addressable aspect of Parkinson's disease. By integrating psychoanalytic insights with medication management, we can provide a more comprehensive care addressing not just the physical symptoms, but the profound psychological and relational dimensions of sexuality in Parkinson's disease. The cases we explored illustrate how psychoanalytic approaches help individuals and couples navigate these complex challenges, finding new pathways to intimacy despite or alongside PD's limitations. By breaking the silence around sexuality in PD, we contribute to a more holistic care that honors the full humanity of those living with this condition. Thank you for your attention to this vital topic. And now April and I will welcome your questions and any reflections.
Okay, so I'll leave this screen up just for a little bit here, so that anybody who wants to, take a picture with your cell phone, jot it down. This will be very helpful to you if you need to explore anything psychological in the future. So, Allison. Wow, lots to unpack. In the meantime, while we are just kind of leaving this slide up for another 30 seconds or so, let's make sure everybody knows they can go put their questions in the Q&A bubble. So at the bottom of your Zoom screen, you'll see, different little pictures. Pick the one that says Q&A. It looks like a bubble that you talk into. Go ahead and type your questions in now. And what we will do is answer those. Sorry, let me just almost lost power here for a second. Hang on one sec. There we go. I might appear a little dark for a minute. Okay, now Let me close out. And again, anybody who registered for this, we are going to mail this out, email the contact information for Allison out. And let's just see if anybody is putting anything in queue. No Q&A yet? Oh my. Okay, I'm surprised about that. Let me grab my notes. Give you guys a little bit more time to think of some questions because it is a very, very important topic. Although I do have to say that there's not really a lot of coverage out there in the PD world for this topic. I do feel like people do broad strokes, right, when it comes to sexuality, and nobody's going to really drill down. So I hope that some of you take this opportunity. You have, a psychologist here. She can answer some questions for you. But listen, I have to say that my eyes were open today, Allison. Thank you. I was really listening to a lot of the things you were saying, and I think that one of the biggest things to remember is that our body is really, such an integral part of, our consciousness, right? And our subconsciousness, really our subconscious. And I feel like, if you have a chronic illness like Parkinson's disease, of course that's going to affect how you're seeing the world, feeling the world. So these are really important topics. I wrote a lot of notes, so let's see if anybody has a question before I get into any of my notes. Oh, yeah, there's a couple. Let's see what we have here. Okay. I will read it. I still have a strong libido. However, my wife says she is no longer interested in sex. I just witnessed 8 years of no sex with my wife. Along with my 8-year PD diagnosis, she doesn't even touch me anymore. And is this a normal response? That's a great question. And I just want to say thank you for putting that out there.
Yes, I have a feeling that you're not the only one who's experienced this. Um, I think like with our case studies, there's so many components to a person, much less two people. So there's so many factors, cultural, psychological, biological, that I can't comment particularly on your specific relationship, right? But what interests me about your comment is the timing. So you said 8 years of no sex with your wife, along with 8-year Parkinson's diagnosis. I don't think that's not a coincidence, or I don't think that's just coincidence, right? I think there could be something to that. I would wonder what changed. Obviously, there was a diagnosis, and particularly that usually comes off the heels of symptoms, right? How I would explore meanings, both for yourself and with your partner, either an individual psychodynamic therapy or couples, right? So that's where I would begin. And, I do want to normalize these concerns too. So when you say normal response, we are going to have unique responses to everything. But I think what we saw in our case studies is you're not alone.
Mhm. Absolutely. And I mean, who knows, right? It could be the caregiver. The caregiver has the I guess when it comes to what you were talking about, and I'm looking at my notes to see, like not knowing if you're the lover anymore or the parent anymore as you are giving care to your partner.
Mhm.
So, yeah. All right, let me mark that as answered. Thank you for that question. Okay, next question. What is an OTPT role other than a referral? Mm,
Well, I mentioned OT in Maria's case study because when I was doing some research on sexuality and PD and the current clinical literature, that sometimes there's not much research out there. But when I did see suggestions and recommendations, some authors would be recommending going to an OT or PT for modifications of positions, in intimate acts, or different like tools or, just modifications and accommodations. So that's what I saw. And I think there could be a role there. I mean, in analysis, we don't necessarily we don't give advice, much less suggest, certain toys or certain positions, unless they sort of come up in meanings and sort of through our work. But there's roles for other providers in the comprehensive team too.
okay, that's a good, all right, thank you for that one. me mark that done. All right, let me read this next question. I observe caregivers are less comfortable with intimacy, fearing it will suggest they want sex. Can you speak to this dynamic where the person with PD wants more intimacy and feels rejected by their partner who does not?
Mm. Well, I think we should first start by fearing or exploring the fears around what it would mean to suggest wanting sex. Um, it sounds like that's a morally shameful thing implied in that topic, right? So that might be first what I would explore. What are the
Hmm.
fears around desire? What does it mean to assert that desire? Right. And then particularly in that caregiver patient dynamic, what does that mean? Like with one of our case studies, we discussed how this reverted back to sort of a child-mother dynamic and even how that was reversed in the parent-child relationship. The parent was the patient, right? The child was sometimes a caregiver. So there's so many layered aspects to this. Um, the more that, let's say, me in the professional setting or your neurologist or your PT or whomever you're being treated by can broach topics of intimacy, I think the better. So did it speak to your question? I think I spoke to the dynamics.
Mhm.
Yeah, I hope so.
Yeah, and I was kind of thinking like maybe she means, I don't know, I'm reading between the lines here, so you'll have to let me know. Maybe she's talking about the hypersexuality, perhaps, that the person with PD might be feeling, and then the partner is just not wanting that level. I don't know. I'm reading between the lines, but
Yeah, I mean, there's a lot more questions
mhm.
I would want to explore rather than give
Yeah, of
answers to. But like you
course.
said, intimacy is different from sex. It can mean a whole bunch of different things. So I would really want to hone in session what intimacy is in this context.
Hmm. Good. I love that we're just at least, hearing people's questions so we can get
Absolutely.
an idea. This
Yeah,
is
it's
good.
exciting.
Let's see the next one. How do you assess whether an issue is more physical than mental or PD related versus being an older man? Good question.
So an essential part of psychoanalytic work is suspending confidence that we have the answer. So, meaning, I don't want to come in and declare that I know what's what and label the physical from the mental. I hope through the discussion today, we saw that the mental is the physical is the mental. It's so hard to parse these out, probably impossible. Luckily, our science, particularly PNI, psychoneuroimmunology, long word, but it's contemporary scientific breakthroughs, honestly, in describing how the psychological is impacted by downstream effects biologically and vice versa. Okay, so this is all related. I don't want to go physical, mental, they're separate.
Sure.
Similarly, with being PD related versus older, that's also a challenge for medical professionals too. How do we say what's just aging and what's PD? And that
Mhm.
that is more in their scope than the neurologist's scope rather than mine per se. But what we would do in session is explore the meaning of that confusion. I don't know if it's about my aging and just growing older or if this is part of my illness and what anxieties come up around that. It's
Mhm.
confusing and it's hard and I don't know what's what and I'm losing my grip.
Exactly. That's well put. And also, I've had conversations, sometimes after support groups with women who have PD, and they'll say, I don't even know if this is old age or menopause. Like there's a whole nother layer to women's sexuality that they have to think about if they have Parkinson's.
Mhm.
Yeah.
And I have to say, I didn't see much of that discussion in the clinical literature.
Yeah, I bet
I can
not.
film all of it. I'm sure it's in there somewhere, but there's not a whole lot.
Not talked about enough for sure.
The intersectionality between women's sexual health, women's health, PD, and then you get into age. If you combine all of those, right? Let alone even for LGBTQ individuals or
Exactly.
BIPOC individuals or transgender, it becomes lesser and lesser studied and known. So I appreciate this conversation.
Yeah, this is great. Great conversation. And a first for Neuro Challenge, I must say. Okay, let's see. Any significance to PD hallucinations combined with PD and visual auditory images and auditory sound being so sharp that the patient insists they are real?
So
Mm.
when I do intakes in the hospital, so I've seen probably 1,000 patients over the last year conducting intake assessments, meaning the first person the patients talk to about why they're coming into the inpatient crisis hospital. We get a lot of folks who struggle with hallucinations. And I don't ask them, are you seeing or hearing hallucinations? Because they're going to say, no, I'm not seeing or hearing anything that's not real. But if I ask in a different way, do you see and hear things that I might not be able to hear or that others around you can't see? Well, yeah, technically, I saw a shadow of a demon in my room the other day. My mom thought it was the cat. Okay, so it is based on the language we're using and understanding the mentalization that reality. They are going typically, not always, typically perceive these hallucinations to be real. Sometimes they feel real and there's distress. Sometimes they know they're not real and there's still distress. Okay, but yes, that's the starting point. And as for the significance with sexuality, in that case study where we described the mother with postpartum psychosis, um, this comes up, and it comes up in the context of PD, and then with sexuality, there are many meanings too.
Mm-hmm.
Mhm.
That's interesting. Okay. And let's move on to next one is since so many get the diagnosis about the same age as decreasing hormones post-menopause, I'm wondering if a female decreased libido is also the problem versus the caregiving.
Yeah, I mean, I think that's similar to the other questions around age versus, PD diagnosis is there's so many, people are complicated. There's so many factors we can't, you
Sure.
know, the clinical literature and our clinicians are honing in on a diagnosis to treat that. If they're comprehensive, which most professionals are, then they can understand that the condition is happening in the context of multiple factors, multiple identities in one person. They should be able to have conversations. And if not, I hope you feel safe and comfortable talking to them about this, about what is postmenopause and whether the decrease in libido is impacted by this or that. Probably, I'm not going to claim I know scientifically, but probably it's a lot of things.
Yeah, and also going back to something you said earlier, there's just the self-esteem after being diagnosed with a, chronic disease like this, the changes that are going on in your body. Um, and you said like uh, altered self-image. So the altered self-image, right? Like I'm not talking about hallucinating altered state, self-image, but just how you perceive yourself. You're really not yourself anymore. You're a different person.
Yeah,
Yeah.
yeah. And so it might be a secondary effect of the illness, like altered self-esteem. It might be also a primary effect of, decreased, dopamine, this and that neurotransmitters impacting our sense of self too, or creating depression that then is creating this, lack of arousal, etc. Right? There's
Mhm.
so many paths to Rome.
Yeah, exactly. Okay, the next question, she just says, okay, that was the answer. Okay, maybe we answered something. Next one, I have never tried to get help because I don't know where to find the right place and if it is covered by insurance. Any advice?
Yeah, classic American healthcare problem, right? You want to find the right provider as well as, meeting your financial needs. Um, Depending on your budget, depending on your insurance, and whether you want to use insurance, would steer where you look. For example, for folks with more limited means, you may want to check out a community healthcare center or start with neurochallenge support groups, right? I'm pretty sure they're
Mhm.
accessible. I'm
Mhm.
pretty sure they're low cost, if no cost, right? So starting,
Zero, they're free.
okay, there we go. So step, ground zero, right?
Right.
Um, I think somewhere online too, right? So.
Mhm.
Know that. Another step could be calling local community health centers, speaking with your other treatment providers. If you have a good neurologist, who do they know? Who's in their area? Um, Lastly, if you're looking for folks who do work like myself, that would be psychoanalytic mental health therapists or psychoanalysts. Largely, we don't work with insurance, not because we don't want to, but because it's very difficult. That being said, there's advantages. You have greater confidentiality. You can see us more often. You're not going to get kicked out. We can do all the good work without having someone over our head asking what we're doing and trying to meddle with, our affairs. So sometimes you get what you pay for, or sometimes you can get lucky and find someone who does take insurance.
Mhm.
So I would, if you're not in the Gainesville or Florida area, you can't come to me for whatever reason, you could try going to APSA, APSA, American Psychoanalytic Association, and go to Find a Provider, and you'll see who's on that list in your region. They may have sponsored or low cost sliding scale options available, or they may not, but it might also be worth the investment. That's going to be up to you.
Yeah, I do think therapy like this is worth the investment. Do you do telehealth?
Mhm.
Okay, so not just in person in Gainesville, people can be anywhere.
Mhm.
Okay, good to know. Great to know. Another thing I'll let everybody know because this question just came up is that NeuroChallenge has care advisors. These are people who have been trained in Parkinson's disease information and resources to provide. And so if you are looking for a psychotherapist, a counselor, any type of extra mental health supports, you can reach out to us, and for absolutely nothing, we will provide you with different providers, and you can take it from there to find out if, which one fits your budget or your insurance or just your personality. So reach out to us because we'll be able to give you names, and Allison is one of those. All right, let's see. We'll answer that one. Last question. How does autism in someone with PD affect sexuality? Good question.
Well,
Hmm.
I think when we look through our case studies, we see that Parkinson's affects sexuality in a myriad of ways, right? And our sexual selves are multiplicitous anyway, and our genders and our sex are multiplicitous anyway. So again, the individual is complex and unique. Adding in autism, again, autism manifests in many different ways, right? And there's even, developing understandings and renewed conceptualizations of what that even means in our society. There's a widening definition. Um, in session, I would focus specifically on that individual, on what is autism in your life? How does it express? What does it look like? What do you feel you're limited or not limited to? How does this benefit you? What the ways in which you think and feel and believe, you know, about yourself, about others of the world, just like every other patient, right? No different in that respect. Also express sexually. Also with your PD diagnosis. How do these all communicate? And we may not have a one sentence answer. It might just be ongoing exploration in our psychoanalytic therapy.
Mm-hmm.
Yeah.
Yeah, yeah, good. So, real quick, because I know we're past 1 o'clock. I'm actually learning a lot about attachment theory myself right now, so I'm interested to hear your answer. When people, sometimes we'll hear that people will have a physical thing happen, like a fall, ends them up in the hospital, then suddenly they have this PD diagnosis that they never knew was underlying, right?
Mhm.
Is that kind of the same with attachment theory? Like sometimes you have like a mental crisis or a situation that, happens, and then suddenly you realize that you actually have some of these childhood wounds or whatever they're called, where you are dealing with an attachment theory issue or an attachment dysfunction, I think it's
Mhm.
called. I mean,
Mhm.
no, it doesn't have much to do with PD, but I imagine like it's the same where suddenly you have these issues that you didn't even know were there.
Yeah, yeah. Sometimes it's a slow creep with a prodrome, and other times it's a sudden aha moment of, oh, yeah, that reminds me of that thing that one time or
Hmm.
long time that happened. Yeah, I think that sort of temporal disruption, that suddenness, that spontaneity, that realization, I think,
Hmm.
yeah, in the same way that you can realize something physical is happening, you can always realize something is psychologically happening too.
Right, right, right.
Yeah.
Wow, so much information. Allison, this was amazing. I absolutely love this topic. I'd love to do this again sometime with you where maybe we can explore it even further. But thank you for your time and your expertise. And again, thank you to everybody out there for tuning in. Again, this will live on our YouTube channel once we get it all edited up. And I'll be sending out an email with her contact information to you. So thank you, Allison.
Absolutely. Thank you. Thanks, April.
Every, yeah, everybody out there, have a great day. Bye-bye.